third-party payment systems in American medicine are currently undergoing drastic changes. Market forces, primarily employer-driven, are leading to the introduction of a greater percentage of managed care plans, such as HMOs and PPOs, over traditional indemnity insurance. Americans continue to spend more money per capita on health care than any nation on earth, a whopping total of $884.2 billion in 1993, the fastest growing slice of the GNP at 13.9%. As our government and major employers have made abundantly clear to us over the past 2 years, they are growing weary of footing this ever-increasing bill. With the stunning failure of national health care reform, only managed care strategies currently remain as viable cost cutters. But though highly touted by some, HMOs thus far have only been able to record modest cost savings of 6 to 7%. Nevertheless, managed care is currently what the market wants, and as one HMO executive recently put it, the marketplace always wins. In 1988, indemnity insurance accounted for 72.6% of the private health care market. By 93, it had shrunk to 33%, leading some to predict its impending death spiral. The same time interval has seen the ascendancy of PPOs with discounted fee schedules and the steady growth of HMO enrollment. It has also seen the birth of what some feel are the more patient-friendly POS, or point of service plans, which do allow patients more freedom of medical service selection, but at a greater personal cost. Doctors in many parts of the country have felt compelled to sign up with managed care plans or else lose a sizable portion of their patient base. A recent survey shows that 3/4 of private physicians are enrolled in at least one managed care plan in 1994. Physicians are exhorted by leading medical journals to participate in such purported cost-cutting plans as our societal duty in the face of a, open quote, limited resource economy, close quote. There are significant voices of dissent, however. Dr. G. Gale Stevens, arguably the chief exponent of family medicine theory, writes, quote, "I believe that the gatekeeper role is hopelessly conflicted, ethically unmanageable, clinically naive, professionally ungratifying, and historically unnatural for a family physician," close quote. He goes on to write, "I cannot imagine that apart from defensive economic strategy, well-informed physicians or patients would choose a gatekeeper model of medical care on its non-economic merits," close quote. Indeed, the economic necessity of such a system, at least in the private sector, is suspect when one examines the salaries of some of the leading chief economic officers in the HMO industry. Are medical resources in the U.S. private sector truly limited when the top 10 chief executive officers of our for-profit HMOs earning salaries of up to $3.6 million per year? Let me say at this point that I do concede that there are indeed limited public monies earmarked for health care, such as Medicare and Medicaid. I also concede the urgent need for better stewardship of private sector health dollars, although I remain unconvinced of the need for some emergently imposed forced rationing system. I can perhaps best graphically show you why clinic administrators are becoming enamored of capitated health plans such as HMOs these days. These slides are provided to us by Joe Mittling, and I would like to thank him for these. The following graph, I'm sorry, it's very difficult to see here. Basically, the following graph shows almost the linear decline of gross collections. This is gross collections going down, while at the same time revealing an increased percentage of clinic revenue from adjusted are discounted fee-for-service charges. So in other words, gross collections down linear fashion. The percentage of collections coming from discounted fee schedules is increasing. If you look at the following graph, you see the old traditional fee-for-service system. We have dollars on the dollars of revenue on the y-axis and volume of services on the x-axis. Notice here the sizable margin for profit. My light bulb went out. Look at the profit margin you have here. Now look at the next slide. This is a discounted fee-for-service system, such as a PPO plan, discounted. Notice the decrease in the profit margin, much smaller than on a fee-for-service plan. Healthcare administrators, clinic administrators begin to furrow their brows at this point when you show this slide. No wonder they consider PPOs to be only a transitional form of managed care. But now look at the economic magic created by a capitated healthcare system. Capitated meaning a fixed amount of dollars covering a fixed amount of patients. Suddenly, the profits and losses are reversed. You see the reversal there. And the whole game plan for healthcare delivery is reversed. As you will recall, with the two previous systems we talked about, fee-for-service and discounted, a physician is paid proportionally to the amount of service he provides. Under a capitated system, however, as one of our clinic consultants recently told us, you do more, you get paid less. Now, the subliminal message to us at this point being whispered in our ear, like the little demon on our shoulder says, but look at all the money you can make for doing next to nothing. Do less, get paid more. And here's the moral rub in the matter, but we'll look at this more a little bit later. Now, by now, some in the audience are wondering, when is this guy going to stop talking economics and start talking about ethics? But don't you see, that is the whole point in this issue. In contemporary managed care debate, it is often felt to be axiomatic that economics precedes ethics. Economics precedes ethics, to borrow a phrase somewhat from Sartre, or perhaps it's Marx. But indeed, it appears that ethics are often only an afterthought, designed merely to justify managed care strategies. Indeed, Mary Devlin of the AMA's Council on Ethical and Judicial Affairs reflects this when she writes that it remains to be seen, quote, whether the original pattern of medical ethics can be retained while undergoing modifications needed to meet the requirements of a changing technological, economic, and social environment. In preparing this paper, it was somewhat frustrating trying to find writings on the philosophical, theoretical, or psychological underpinnings of managed care. A Medline search of articles devoted solely to this issue was fruitless, leaving this, in my opinion, a fertile field of research for budding young Christian bioethicists. Nevertheless, upon reviewing the currently available literature on managed care, it still seems possible to arrive at a rudimentary gestalt of its underpinnings. In keeping with the spirit of our contemporary postmodern age, these underpinnings are really a rather eclectic blend, which I think reflects the conflict inherent in managed care theory. The true blue evangelist of managed care, and believe me, some of these people are as zealous as an evangelist, will tell you, he typically begins his sermon by appealing to the social conscience of the physicians in the face of a limited resource economy. Vague reference is then briefly made to the concept of distributive justice, a la John Rawls. The sermon is sprinkled throughout with business management jargon, capitation, case manager, clinical economist, rationing, etc. The chief doctrine espoused is that of classical utilitarianism, providing the greatest good to the greatest number of people, translated in managed care terms as more people provided with adequate access to medical services. Now, never mind the fact that such a utilitarian philosophy has always proven more theoretical than practical. But who knows, maybe we could revivify the mummy of Jeremy Bentham, and he could provide us with some sort of new managed care calculus to guide us. As the managed care sermon draws to a close, its evangelist pulls out a powerful psychological weapon to draw in the unconvinced physician, that of economic behaviorism. Economic behaviorism. If the physician does not act to decrease overall healthcare consumption, she will be punished economically with a lower take-home pay, while the shrewd clinical economist, formerly known as a physician, is promised a bonus for her efforts. Remember, do less, you get paid more. David Sulmasy notes recently that America's current infatuation with managed care is somewhat anticipated in the well-known work of moral philosopher Alistair McIntyre entitled After Virtue. McIntyre describes the late 20th century as a period of managerial revolution, but he goes on to decry the fact that this so-called managerial effectiveness is nothing more than a moral fiction. A moral fiction, he says. He writes, managerial effectiveness is the name of a fictitious but believed in reality appeal to which disguises certain other realities. Close quote. What are these certain other realities that are being disguised, you ask? Well, McIntyre says that they are all that is systematically unpredictable in human affairs. As enumerated by Sulmasy, these include, quote, the conceptual innovations, the unforeseen consequences of unmade individual decisions, the indefinite reflexivity, imperfect knowledge, and multiple simultaneous relationships that constitute our personal interactions, and the pure contingency that characterizes so much of our human history in the making, close quote. To put it quite simply, life is too unpredictable to think that we can bureaucratically micromanage it, and I contend that the practice of medicine is as likewise unpredictable. I don't know about you guys, but somehow my patients never seem to fit those described in the available practice management guidelines. Perhaps the most significant feature of America's managerial revolution as far as this conference is concerned is the current advancement of the concept of managed death, otherwise known as euthanasia and physician-assisted suicide. Certainly the adoption of such a term as managed death is simply a euphemism to lend a cool, swift professionalism to what we here would consider a callous disregard for human life. The increasing public debate over the concept of managed death occurring simultaneously with managed care's still young and impressionable policy formulation merits close scrutiny. I would recommend your attention to an article by David Sulmasy entitled Managed Care and Managed Death, found in the Archives of Internal Medicine, January 23, 1995, for further reading on this matter. Sulmasy, in a section of the article entitled The Logic of Being a Burden, notes a perilous line of argument whereby these two movements, managed care and managed death, could chillingly converge under the guise of cost containment. The argument is as follows. Number one, too much money is being spent on health care. Number two, certain patients are expensive to take care of, those who are physically and mentally disabled and the elderly. Number three, these patients appear to suffer a great deal and lead lives of diminished dignity and are a burden to others, both financially and emotionally. Number four, recognizing the diminished dignity, suffering, and burdens borne by these persons and those around them, their right to euthanasia or assisted suicide should be legally recognized. And number five, this is the point for the HMO side, the happy side effect will be healthcare cost savings. Sulmasy said this is a perilous argument we might face. Time will only tell if such logic comes to fruition despite our resistance. Needless to say, The majority of primary care physicians I know approach capitated health care with a sense of ambivalence. We're all for eliminating unnecessary medical spending. We're all for better preventative health care and patient education. And we're all for treating our patients at the most appropriate level of technological intensity. And we care deeply for the economic plight of our country. But as physicians of the Hippocratic tradition, as physicians who follow the ethic of the Good Samaritan, we've got to take care of the patient on the table in front of us first. As Edmund Pellegrino has so passionately exhorted us in his ethical works, our primacy of obligation is to our patients, not to third-party payers, and not even to society as a whole. Indeed, society itself will benefit when each of its individuals is treated with such primacy. Pellegrino writes, quote, "It is important to realize that most of practical ethics consists in resolving conflicts of obligations. To resolve moral conflicts usually requires an ordering of obligations in accord with some governing principle. In the case of medicine, we do have an ordering principle. That standard is the covenant of trust we enter every time we ask a patient, 'How can I help?'" Close quote. That's our ordering principle in medicine. The patient comes first. Current managed care theory in subtle fashion calls into question the idea that we should give primacy to our individual patients' medical needs without simultaneously giving due consideration to the economic solvency of the health plan, be it private or government funded. Now, never mind the fact that we as physicians never have nor will know how much money is available in the healthcare coffers at any one time. Gail Stevens calls this the great actuarial secret of HMOs, the hardcore calculation of utilization and expenditure that cannot be exceeded, but is a secret closely guarded and kept from physicians and subscribers alike, close quote. The traditional relationship between physician and patient can be described as a covenant of trust in which physicians serve patients' medical needs with competence and beneficence. The physician acts singularly for the benefit of the patient. Managed care or capitated health care posits a new element in this relationship, that of rationing. Rationing requires that a fixed allot of money cover all the medical needs of the population in question. It implies the potentiality that an individual may be denied necessary and effective treatment if funds are felt to be insufficient or if resources are felt to be better utilized elsewhere in the plan. Physicians here are forced to act, as Marcia Angel describes, as double agents, expected to decide whether the benefits of treatment to their patients are worth the cost to society. Such double agency poses a direct threat to the Hippocratic and Christian traditions of healing, as it erodes the relationship of trust that is vital in the physician-patient relationship. The patient is left to ask, is my physician's advice based on what's good for the health plan or society, or what's good for me? And I would argue that rationing is not an appropriate primal duty of the physician. But at the same time, I suggest that a physician is always obligated to act with thrift or economy. Such terms denote wise stewardship of available resources, elimination of waste, and refusal to provide unnecessary or ineffective medical care. To my thinking, such notions are already implicit in the definition of physician competence. Needless to say, the primary care physician as gatekeeper or entry point into the healthcare system faces numerous practical ethical dilemmas on a daily basis. Sulmacy refers to these ethical challenges as moral stress tests for physicians in managed care. This is not to say that medical practice under fee-for-service is or was a state of moral purity. We all know colleagues who have overtested and overtreated for personal economic benefit. Ethical temptation is more intense under managed care, however, due to the ever-present threat of economic punishment to the physician for alleged overutilization of services. The following is a brief listing of some of the moral stress tests for physicians as gatekeepers, primary care physicians. Number one, physician-patient estrangement. We've already alluded to the roots of this potential adversarial standoff. Gail Stevens writes that even under the best of circumstances, quote, gatekeeping has turned me and my patients into a gang of wheedlers and sharpies, each trying to outfox the other for petty privileges and paltry savings. Number two, stretching clinical competency. Here, the primary care clinician potentially compromises the patient's health by attempting care beyond her competency. This is a clear violation of the principle of beneficence. Number three, gaming the system, gaming. This involves distorting patient information in order to assist patients in the acquisition of medical services. We deceive ourselves if we resort to such ends justifies the means argumentation. Number four, skimping on preventative services. Managed care prides itself on the provision of preventative health services such as immunizations, pap smears, and mammograms. With the current turnover of patients in HMOs, however, there exists the temptation to skimp on these services, especially immunizations, and to leave it to the patient's next primary care physician to provide. Number five, skimming of patient populations. Skimming. Under capitation, a physician's inclination is to choose a younger and a healthier patient population in order to preserve the capitation pool. Number six, churning patients. Churning. Medicaid patients have been the victims of this practice before. Here the physician sees multiple HMO patients with rather short shrift while allotting more individual time and attention for his fee-for-service patients. The HMO patient quickly realizes that he or she has become a second-class citizen. A variation of this practice would be the allotment of choice appointment times to only the fee-for-service patient. Such a practice would serve to discourage capitated patients from seeking medical care. The above list, although certainly not exhaustive, I believe is representative of some of the many moral temptations that primary care physicians will face under capitated health care. Well, so what's a primary care physician to do when faced with the realities as we've discussed? I believe it is clear that for many of us it will not be possible to opt out of managed care and still provide for our own families. We all know that most institutions and systems are neither black nor white, but varying shades of gray. And I believe this holds true for the old fee-for-service medicine as well as the new managed care medicine. As Christian physicians, we must work hard for the very reformation of managed care, even as it exists now only in its formative stages. And we must sit in on the appropriate committees as perpetual advocates of patient care. We must serve as examples to our fellow physicians by delivering competent health care to all with economy and thrift. And we should remain open to advice from clinical outcome studies or practice guidelines. We should listen to that advice. Managed care companies must be made accountable to patients and provide full disclosure of covered services and restrictions. They don't do that now. They don't do it. Exorbitant profits of HMOs must be channeled back into patient care and not into CEO salaries. And finally, we must assure that those under our care, our patients, we must assure them that the physician-patient covenant of trust will forever remain inviolate.